Hi, Assalamu alaikum. It's me, Dr. Muhammad Kazafi, and I am trying to present one very important topic. And actually, the topic is that the carotid artery stenosis, and then I will simultaneously present the carotid artery stenting. So, I want to discuss the detail of the carotid artery stenting simultaneously here. So, first of all, as you know, as the introduction, the distinction between the hemodynamic and embolic stroke in the setting of the chronic internal carotid artery occlusion is important. And embolic symptoms are those of classic stroke or transient ischemic attack, and typical are focal. Symptoms may include contralateral motor or sensory deficits or amaurosis, but hemodynamic symptoms may be similar to those of classic stroke or TIA, but may also be less predictable and atypical. Patients have reported symptoms such as limb shaking, retinal claudication, headache from the large pulsatile external carotid artery, collateral and syncope, and generalized fatigue. So, for determining the difference between the hemodynamic and embolic stroke in the presence of chronic internal carotid artery occlusion is important. Embolic symptoms may be from classic stroke or transient ischemic attack, but symptoms may include contralateral motor or sensory deficits as well as amaurosis fugosis. So that's why hemodynamic symptoms may be similar to our classic stroke or TIA, but may also be less predictable and atypical. Patients have reported symptoms such as the limb shaking, retinal claudication, headache from the large pulsatile external carotid artery, collateral syncope, and generalized fatigue. 1/3 of all strokes are related to the cervical carotid disease, but standard risk factors of coronary and systemic atherosclerosis such as age, male sex, family history, smoking, hypertension, hyperlipidemia, sedentary lifestyle, and high dietary fat apply to this patient's population. The mechanism of cervical carotid stroke is usually embolization from the carotid bifurcation plaque, but hemodynamic compromise from stenosis may also play a role. The risk of embolization and hemodynamic compromise increase with increased carotid artery stenosis. So here, if I consider the etiology, carotid artery stenosis is a consequence of systemic atherosclerosis disease. Thus, any risk factor predisposing a patient to progressive atherosclerosis can potentially manifest itself as stenosis of the carotid artery with resultant ischemic stroke and TIA-like symptoms. Risk factors include smoking, hyperlipidemia, male gender, and age. In a minority of patients, especially young female with stenosis of the carotid artery, fibromuscular dysplasia play a much more significant role, and fibromuscular dysplasia is non-inflammatory, non-atherosclerotic process affecting the carotid and renal arteries. Although it can occur elsewhere in the medium-sized vessels, and fibromuscular dysplasia usually occur in the mid and distal internal carotid artery, sometimes extending into the intracranial region. So aneurysm may also be a component of the disease process. Carotid artery stenosis, as I mentioned, is a consequence of systemic atherosclerotic disease and any risk factor predisposing a patient to progressive atherosclerosis can potentially manifest itself as stenosis of carotid artery with resultant ischemic stroke and TIA-like symptoms. Risk factors include smoking, hyperlipidemia, male gender, and age. In the minority of patients, especially young female with stenosis of carotid artery, fibromuscular dysplasia play a much more significant role, and fibromuscular dysplasia is a non-inflammatory, non-atherosclerotic process affecting the carotid and renal artery. Although it can occur elsewhere in the medium-sized vessels, and fibromuscular dysplasia usually occur in the third and distal internal carotid artery. So sometimes extends into the internal or intracranial region, and aneurysm may also be component of the disease process. Symptomatic internal carotid artery occlusion has an incidence of 6 per 100,000, though the rate of asymptomatic chronic occlusion is unknown or may be higher. Internal carotid artery occlusion is a known risk factor for stroke in the United States, and 1/3 of all stroke are related to the carotid occlusion disease. Actually, I couldn't find the very valid data from any other part of the world. That's why I am mentioning as a reference from the data from the United States, because their states, their data is very valid and easily available to discuss and present in front of you people. Stroke ranks third among all cases of death in US, so behind heart disease and cancer. So heart disease and cancer first and second, and the stroke is a third respectively. So about 55,000 more women are affected. Approximately 60% of all stroke deaths occur in female. African American and Mexican American have a higher risk of stroke compared with the Caucasians. So thus, diagnosis, prevention, and treatment of carotid artery stenosis play a vital role in stroke prevention. Regarding the pathophysiology, total internal carotid artery occlusion results from thrombosis in the setting of chronic stenosis, cardiogenic embolization to normal carotid bifurcation, or carotid dissection may also cause total occlusion of internal carotid artery occlusions. Acute occlusion may result in carotid artery stroke. A previously asymptomatic chronic internal carotid artery occlusion may become symptomatic if related to embolic or hemodynamic issues. Embolism may occur from the ipsilateral external carotid artery via collateral to the cerebral circulation. It may also happen when there is a occult patency of the occluded internal carotid artery occlusion, which then serve as the source of embolic material. Hemodynamic insufficiency may occur when any condition that interferes with the cerebral perfusion, such as orthostatic hypotension or volume depletion or cardiac failure, is superimposed on the carotid occlusion, especially when the contralateral carotid disease is significant. Usually, patient will present with the recent stroke. They have slurred speech, cranial nerve deficit, limb weakness, or visual disturbances, which either has resolved or should be expected to improve within 48 hours. Otherwise known as transit ischemic attack, and typically history and physical examination are notable for a patient in their 70s and 80s because they may have history of smoking, high lipid profile, sedentary lifestyle, and this is imperative to realize that the carotid artery atherosclerosis disease is not a segmental disease, rather than it has a propensity to involve other arteries in the human body. So of concern are the coronary arteries, hence it's the prudent for this patient to undergo a cardiac evaluation should surgical intervention be contemplated in treatment the degree of stenosis. For the evaluation should include but not be limited to thorough physical examination. The physical should be coupled with the diagnostic imaging, computerized tomographic scan of the head, followed by telemetry, floor admission, as only a third of ischemic stroke are due to carotid artery disease. The remaining is due to the cardiac embolic phenomena, and the consultation with the stroke specialist like a neurologist as well as cardiologist is of paramount importance. Regarding diagnosing carotid artery stenosis, one usually starts with the least invasive, inexpensive test such as the carotid duplex. And this examination typically show a high resistance signal in the carotid bulb and the very proximal internal carotid artery. Distally, there are no Doppler signal audible in the carotid artery. As a confirmatory test, some form of contrast examination such as digital subtraction arteriography, magnetic resonance arteriography, or computerized tomographic arteriography is required to confirm the diagnosis and plan a surgical approach. Gadolinium enhanced MRA is better for differentiating high-grade stenosis than the time of flight, which sometimes overestimate. Conventional angiography is the gold standard for diagnosis. Acute symptomatic carotid occlusion should be treated with urgent revascularization. In select cases with an immediate presentation, this can be accomplished with carotid endarterectomy or interventional technique include thrombolysis. And in the setting of the chronic total internal carotid artery occlusion, medical management is preferred over neovascularization. However, several special clinical indications exist for procedural intervention. Ipsilateral hemodynamic symptoms is the setting of ipsilateral internal carotid artery occlusion, and contralateral internal carotid artery stenosis may benefit from the contralateral internal carotid artery revascularization to ameliorate hemodynamic insufficiency. Ipsilateral embolic symptoms in the setting of ipsilateral internal carotid artery occlusion and ipsilateral external carotid artery occlusion stenosis may be treated with ipsilateral carotid endarterectomy revascularization or external carotid artery revascularization to eliminate the source of embolization, which occur via enlarged external carotid artery collaterals. Ligation of ipsilateral internal carotid artery also eliminate a source of embolization. But finally, ipsilateral hemodynamic symptoms in the setting of the patent contralateral carotid artery symptoms and ipsilateral internal carotid artery occlusion and ipsilateral external carotid artery stenosis indicate ipsilateral external carotid artery revascularization to improve ipsilateral hemodynamic flow. For patients with symptomatic carotid occlusion, 50 to 99% of carotid endarterectomy was done within 2 weeks of the symptom, and the number needed to treat to prevent one stroke is 5. The number needed to treat increased to 125 if it has done more than 2 weeks of symptoms of stroke onset. So carotid endarterectomy is beneficial if the symptoms are non-disabling with no tandem stenosis or high-grade stenosis. That's why carotid endarterectomy can be deferred if the stroke is too big. and contralateral carotid occlusion hemodynamically instability and contralateral laryngeal palsy is a relative contraindication. There is more myocardial infarction associated with the carotid artery carotid endarterectomy. Carotid artery stenting is a preferred asymptomatic carotid occlusion, and definitely I will present in detail carotid artery stenting in front of you people. And you know the carotid artery stenting is preferred in symptomatic carotid occlusion when the 50 to 99% with multiple comorbidities and tracheostomy patient with the prior neck radiation or dissection. Usually there is an increased risk of stroke after the carotid artery stenting. Due to the advancement of the stent and the technique, carotid artery stenting is comparable to the carotid endarterectomy in most instances, but carotid revascularization for primary prevention of stroke, which is shown in the CREST-2 disease, which is ongoing and will shed more light on this important area. If we consider the differential diagnosis here, when we are considering the carotid artery stenosis and when we are finding there the carotid artery stenosis, what could be the differential diagnosis in our mind? It could be carotid artery dissection, it could be fibromuscular dysplasia, it could be valvular heart disease, especially aortic valve stenosis, it could be arrhythmia such as arterial fibrillation, it could be mural thrombosis, it could be Takayasu vasculitis, it could be giant cell vasculitis or migraine. There are no specific criteria for surveillance of patients with chronically include internal carotid artery, nor are there criteria to specify the degree of external carotid artery stenosis by duplex ultrasound. A reasonable regime is to follow the patient clinically every 6 months to a year with or without a duplex study. The development of symptoms indicate investigation with imaging of some kind to see if cerebrovascular revascularization is indicated. Enhancing healthcare team outcome and the management of a patient with carotid artery stenosis is with the interprofessional team that consists of a nurse practitioner, primary care provider, internist, vascular surgeon, interventional radiologist, and neuroradiologist. When the patient is discovered to have carotid stenosis, a referral should be made to the neurologist who can determine if the treatment is required. Carotid stenosis can be managed via surgery or stenting. Both have similar outcome in the short term, and the treatment also dramatically reduces the risk of future stroke. Now I want to come to the more popular way of treatment, which is nowadays getting popularity day by day, and it is called the carotid artery stenting. Traditionally, carotid endarterectomy has been primary method of treating high-grade asymptomatic and symptomatic carotid artery stenosis. A carotid endarterectomy involves exposure of the carotid artery and removal of plaque, most typically from the carotid bulb and proximal internal carotid artery via neck incision. However, in vascular surgery, as in many other surgical specialties, minimal invasive techniques have evolved over the years, and this activity describes the technique of carotid artery stenting, and I will try to present the introduction. So, traditionally, carotid endarterectomy has been the primary method of treating high-grade asymptomatic and symptomatic carotid artery stenosis. A carotid endarterectomy involves exposure of the carotid artery and the removal of the plaque, and the most typically from the carotid bulb and the proximal internal carotid artery via neck incision. However, in vascular surgery, as in many other surgical specialists, minimally invasive techniques have evolved over the years, and these techniques offer the advantages of a smaller incision, reduced post-operative pain, reduced potential for the post-operative wound complication, and shorter length of stay in the hospital. So the carotid artery stenting is one of a such technique which can be performed via transfemoral approach or transcarotid approach. A common carotid artery arises from the carotid arch, left or the bi or brachiocephalic trunk, and it divides into internal and external carotid artery. The internal carotid artery provides blood to the brain, while the external carotid artery provides blood to the face and scalp and the neck. So the internal and external carotid arteries from collaterals at several locations, and this is helpful for maintenance of blood flow through collateral circulation in case either artery become occluded, and the aortic arch can be divided into three anatomic types. To simplify, an imaginary horizontal line is drawn through the top of the aortic arch. The common carotid artery arises from the aortic arch from the left side and brachiocephalic trunk from the left side. So it divides into the internal and external carotid artery, and the internal carotid artery provides both the brain, while the external carotid artery provides blood to the face, scalp and neck. The internal and external carotid artery from contralateral at several locations. Collaterals, they have at the several locations, and this is helpful to maintenance of blood flow through collateral circulation in case either artery become occluded. So the aortic arch can be divided into three anatomic types, and to simplify, the imaginary horizontal line is drawn through the top of the aortic arch, an imaginary parallel line marking the origin of the great vessel coming off the arch and drawn from the compression. For a type 1 arch, all great vessels originate close to the imaginary horizontal line drawn through the top of the aortic arch, and if the origin of all great vessels fall within the second parallel line, so this is considered a type 2 aortic arch, and for type 3 aortic arch, the origin of all great vessels fall within the third parallel line. So the angulation as related to the type of the aortic arch has important implication for carotid artery stenting. So the fatty plaque form in the wall of the artery in the neck and then reduce blood flow to the brain, and plaque fragment can break and go up and can cause stroke, and that stent being placed within the carotid artery. The carotid artery stenting is a reasonable alternative to the carotid endarterectomy in select patients with high-grade symptomatic more than 70% or symptomatic carotid artery stenosis. Indication for carotid artery stenting include high surgical patient rates such as severe pulmonary disease or recurrent myocardial infarction or unstable angina or severe congestive heart failure or a history of a prior neck radiation that is anticipated to make open surgical dissection difficult. That's why the history of damage to the contralateral vocal cords. That's why because of the presence of the tracheostomy or contralateral carotid occlusion, and previous carotid endarterectomy has been done with the recurrent stenosis, then the carotid artery stenting is the best solution for that. The main contraindication of carotid artery stenting via transfemoral approach is unfavorable aortic arch anatomy, and this can include a heavily calcified aortic arch or type 3 aortic arch. So then relatively contraindication can be a history of a severe allergic reaction to intravenous contrast dye. However, patient can be pre-medicated to mitigate some of this risk. For a transcarotid approach and a common carotid artery length of less than 5 centimeter from the clavicle is considered inadequate. So then we cannot do that. But if I consider the equipment an ultrasound unit, fluoroscope imaging systems such as the C-arm and I must say the good quality C-arm, then the lead shield, because you can avoid the unnecessary exposure to yourself and your team members and even the patient, the rest of the body of the patient. So this lead shield and sterile drapes, heparinized saline heparin is required for both type of approaches. An ACT machine should be available to ensure that the ACT after heparinization is greater than 250 seconds. And transfemoral approach require the following equipment. That's why the micropuncture kit for percutaneous access of the common femoral artery, then 0.035 inch, or I must say about the and the 0.014 inch wire. So and then 6 French short and long sheet, then angled catheters and angioplasty balloons, embolic protection device or flow reversal system. Transcarotid approach require the following: a surgical tray, vascular clamp to perform a surgical exposure of common carotid artery at the base of the neck and allow for direct puncture of the artery and using a micropuncture kit. Additional wire, sheet, balloon may be used as described, but as you know, a flow reversal system of a neuroprotein against potential embolization. Actually, the procedure list, as I mentioned, we need the vascular surgeon here, and as a first assistant, either he is a fellow, he is a resident, or a physician assistant. We need with the vascular surgeon and the anesthesiologist, radiologist, technician, and nursing personnel, also nursing technician and circulator nurse. And in case of the transfemoral approach, most physicians choose to perform carotid artery stenting under local anesthesia with or without sedation to monitor the patient's neurological status. For the transcarotid approach, either local anesthesia with sedation or general anesthesia may be employed. If general anesthesia is employed, use of intraoperative EEG brain mapping should be considered. It is very, very necessary. In case of transfemoral approach, most physicians choose to perform carotid artery stenting under local anesthesia with or without sedation to monitor the patient's neurological status. For the transcarotid approach, either local anesthesia with sedation or general anesthesia may be employed. If general anesthesia is employed, use of intraoperative EEG brain mapping should be considered. Regardless of the approach, patient should be closely monitored under the procedure. As with the carotid endarterectomy or carotid artery stenting can cause dramatic changes in the patient's hemodynamics, so leading to hypotension or bradycardia. Anesthesia personnel should have vasoactive medication available to treat such hemodynamically significant changes, and it is also prudent to have an arterial line in place of the invasive hemodynamic monitoring during the procedure, and patients should be on aspirin and Plavix and preoperatively, and these should be continued in the post-operative period. All patients should be asked about the aspirin and Plavix use in the preoperative holding area. So for the transfemoral approach, the patient should be supine and the neck should be turned into the opposite side. For the transcarotid approach, and the patient should be supine with the shoulder roll placed under the shoulder and the neck turned to the opposite side. For sterile precaution should be maintained throughout the procedure as with any invasive procedure. And if the transfemoral approach is being used, then both groins should be prepared and draped in the usual sterile fashion. So for the transcarotid approach, the neck should be prepped and draped. In addition to the groin, arms can be tugged for both approaches. As far as technique or treatment, transfemoral approach, this technique is believed to provide better maneuverability. However, it can be limited by aortic arch anatomy and calcification. Under ultrasound guidance, the common femoral artery is assessed percutaneously using the micropuncture kit, using the Seldinger technique, and a femoral angiogram is recommended at this time to identify proper anatomic entry into the common femoral artery and assess suitably for use of vascular access closure device at the occlusion or conclusion of the procedure. A short 6 French sheet is then placed over a 0.035 in the wire, and the wire is advanced into the aortic arch carefully using an angle catheter and left anterior oblique projection into the fluoroscope system, and the common carotid artery is selectively cannulated and mapped, and the guide wire is then advanced into the external carotid artery, followed by advancement of the catheter into the external carotid artery, and over a stiffer wire, a shuttle sheet is advanced into the common carotid artery, and dedicated carotid arteriogram are performed in multiple views to identify the lesion. So when as 0.014 inch wire should be used to traverse the lesion, followed by placement of an embolic protection device. So pre-dilation of the lesion is performed using a small profile balloon, and the careful attention should be paid to the patient's hemodynamic during this maneuver, and subsequently after the pre-dilatation or appropriate size stent is employed if significant residual stenosis exists. After the deployment of the stent, greater than 30% balloon angioplasty can be performed to rectify this, and completion carotid and the cerebral angiogram is performed, followed by the removal of the catheter and sheath if the result is satisfactory, and the closure device is then used to close the arteriotomy site in the common femoral artery. Transcarotid approach, the technique involves direct surgical exposure of common carotid artery at the base of the neck, and the duplex ultrasound can be used to plan the surgical incision over the course of common carotid artery. In addition to the use of the traditional anatomic landmark, dissection is carried out through the subcutaneous tissue using a Bouvier electrocautery, and the platysma is identified and divided, and the common carotid artery is then identified and dissected into circumferential way, and the vessel loop or umbilical tap is then placed under the artery. Additional proximal and distal part of the common carotid artery is dissected out as well. Using a micropuncture kit, the common carotid and distal part of common carotid artery is dissected out as well, and a guide wire is then positioned in the common carotid artery, and the arterial part of the flow reversal system is introduced. The common femoral vein is punctured under ultrasound guidance using a micropuncture kit, and a 0.035 guide wire is then passed into the femoral vein, followed by placement of the venous sheath of the flow reversal system. So the venous sheath is then attached to the arterial sheath, and reverse flow is established. So the carotid angiography is then performed in multiple projections. A guide wire is then used to traverse the lesion, followed by the placement of the clamp over the proximal common carotid artery. After this maneuver, pre-dilatation and stent deployment are performed to treat the carotid artery lesion. Significant residual Stenosis after stent deployment is treated with balloon angioplasty. Following completion angiography, the wire and catheter are removed. The distal common carotid artery is clamped and suture-mediated closure of the arteriotomy is performed using Prolene suture. The neck incision is closed in multiple layers and the femoral vein sheath is removed, followed by the application of manual pressure to achieve hemostasis. For the transfemoral approach, complication can occur related to the femoral artery axis. This include bleeding, perforation, dissection, thrombosis, and distal embolization. Procedural complications from either approach include carotid artery dissection or embolization, and the stent may not deploy properly and can be associated with fracture. There have been multiple studies comprises the carotid artery stenting with carotid endarterectomy in both symptomatic and asymptomatic patients. The risk of myocardial ischemia appeared to be higher with carotid endarterectomy, while the risk of cerebral vascular accident appeared to be higher with the carotid artery stenting. So, re-stenosis rate appeared to be similar between the carotid endarterectomy and carotid artery stenosis after 2 years. So the carotid artery stenting as a procedure appeared to have worse outcome in patient aged 70 years and over, and in the patient with the high burden of white matter lesion in the brain imaging. Therefore, patient selection is important for the carotid artery stenting. The transcarotid approach of the carotid artery stenting potentially reduces the risk of embolization in case of hostile aortic arch. More experience with this technique is being gained in ongoing trial, and then hospitalization and long-term costs of the carotid artery stent and carotid endarterectomy appear almost similar. Carotid artery disease is often encountered by primary care provider, nurse practitioner, and the internist. Because the disorder can lead to stroke, and it is important to refer these patients to the vascular surgeon or an interventional radiologist. Both the open procedure and stenting are viable options for patients with carotid artery disease. Once treated, these patients need to be educated on a prevention of atherosclerosis by changing lifestyle, reducing body weight, and lowering cholesterol, and participating in exercise. So regarding the one case, as an analogy, I have a patient which is 65-year-old male, presented with the TIA, multiple TIA, and then patient initially presented under the neurology. They see the patient and they evaluate the patient, did the CT and MRI. They found there is a microinfarct in the brain, and then the 4-vessel Doppler has been done, and a carotid duplex has been done, and they found there is a 70% blockage in the right side and 50% or 49% blockage in the left side. Though patient has been advised for the surgery and the option of the carotid artery stenting, so we shift this patient for the carotid artery stenting, and I have attended this case. I didn't do by myself, but the team was doing. So I was the observer there, and I have seen how they were doing. So that's why I was thinking that I should present this case in front of you people, how the carotid artery stenting is getting popularity all over the world for the treatment of the carotid artery stenosis. And we had only one option before, the carotid endarterectomy. Now we have the option of carotid artery stenting, and we can do by the two ways, one by the transfemoral way, and other is the transcarotid. And in my patient it has been done by the transfemoral option, but as this procedure has gaining the popularity all over the world, definitely I am sure that with the time this could be the first choice for the patient. Thank you. If you like it, please subscribe it, share it, and support us.